Welcome to another episode of Hema Now, our hematology podcast. I'm your host, Dr. Jonathan Sakia, and I'm thrilled to introduce today's esteemed guest, Dr. Shaji Kumar, who serves as a consultant in the Division of Hematology at the Mayo Clinic mothership in Rochester, Minnesota. Dr. Kumar is also a professor of medicine at Mayo Clinic College of Medicine and Science and holds leadership roles in multiple research initiatives, including as chair of the Myeloma, Amyloidosis, Dysproteinemia Group. With extensive expertise in hematology and oncology, particularly in multiple myeloma, Dr. Kumar has made significant contributions to clinical and translational science. In his free time, Dr. Kumar loves to travel and is an avid photographer. So let's dive into his research and insights today. It's a pleasure to welcome to the Hema Now podcast, Professor Shaji Kumar. Over to the podcast. So, it's a real pleasure to have you here, Professor Shaji Kumar. Welcome.
Thank you, Jonathan.
So, let's start gently. I know you're a lover of travel and photography, and you made it from your birth and your education in India to the wilds of Minnesota. Brave man. I know you're a lover of travel and photography. Where was the last place you visited, and where's somewhere on your bucket list that you've still to venture to?
Yeah, actually, the last one, the trip we had was to Egypt and Jordan a few weeks ago.
Oh, really?
Had a really wonderful trip looking at the pyramids, the Dead Sea, the Petra. It was a great trip and lots of opportunities for taking pictures as well.
Do you like publish any of your stuff online or
I don't. I just file them away, look at them once in a while, enjoy them.
just for your personal? I've actually Egypt and Jordan are on my list for sure. I've seen all the pictures and think, yeah, I'm told that the pyramids at Giza is so much more impressive in person. So
Yeah,
I guess we ought to
spectacular.
get into some hematology stuff. So precision medicine continues to gain traction. There's a growing focus on tailoring treatments based on individual genetic profiles. How does your research on drug combinations and myeloma biology align with the push towards more personalized treatment strategies, especially in patients who are more at high risk?
Absolutely, Jonathan. I think it's a important question in the oncology field in general. And I will focus on myeloma, but many of the things we are going to be talking about with respect to myeloma probably applies to most of the cancers that we have or we do deal with in the clinic. Just like all cancers, myeloma is very heterogeneous. Even though they look and seem like the same thing for different patients, they have very different behavior
Right.
in different patients. And the differences in the behavior is often driven by differences in the genetic abnormalities that happen in the myeloma. But not only the genetic abnormalities, there can also be epigenetic changes. And all of this, one have to remember, happens in the context of individual variations as well. So different people might react differently to the cancer development, also in terms of how their immune system in particular react to development of cancer. So all these differences, the innate differences as well as differences within the cancer cell, uh, combined give rise to clinical behavior that can be very, very different in different patients. So when you think about multiple myeloma, we have roughly about 41,000 patients diagnosed in the US each year. The median survival for this disease 2 decades ago, when I started treating patients with myeloma, was about 3 years. And now we tell patients routinely that their survival is probably in the order of 12 to 15 years and getting better. So we clearly have made dramatic progress in the treatment and improving the outcome of patients with multiple myeloma. However, what we have seen is that this 12 to 15 years doesn't apply to everyone. We still deal with patients who get diagnosed with myeloma. They get treated, their treatment works fantastic, but 2 months later, the disease is back. You go to second line treatment that works for maybe a few months and then it comes back again. And before you know, you're run through the whole list of medications that's available for treating myeloma, and the patients have literally no choice at that point. So we're seeing these extremes, right? So one extreme is this high risk of behavior or very difficult to manage disease. And on the other extreme, I have patients in my practice who were diagnosed 20 plus years ago. They got maybe a year's worth of treatment, their myeloma went into remission, and in some individuals, it's never come back since then. So we are seeing this huge spectrum in terms of behavior, and this is the kind of the basis of us trying to individualize treatment approaches for patients with multiple myeloma, and as I said, all kinds of cancers. So in order to kind of build on that concept of precision medicine, we really need to understand the reasons behind this kind of heterogeneous behavior. And as I said before, a lot of work has gone into it. We know genetics play a major outsized role in terms of its influence on this cancer behavior. But we know the genetics isn't the only thing. We know there are differences in terms of how the immune system is able to control the tumor. We know there are differences in terms of the age of the patients. Sometimes the older patients are less likely to have the immune system that is capable of controlling the disease. But also age comes with a variety of different comorbidities, right? So people can have diabetes, they can have heart disease, they can have hypertension. Now, none of which may individually drive the cancer behavior, but they all influence how well the patients tolerate the treatments we throw at them. Particularly, there are some conditions which might allow patients to, or not allow patients to get the optimal therapy that they should be getting. So indirectly, they are influencing the cancer behavior and the outcomes. So the precision cancer therapy is probably a very imprecise term in a way because it doesn't capture all the nuances of how we may have to change therapy based on a variety of different factors for a given patient.
Right. And I guess there are also nowadays there have to be cost implications. You think about the costs of these new tests, but I've personally been very frustrated as one looks at health economics because the people controlling the purchasing will say, you know, this item is more expensive than the pencil you were using before, but they're not looking at the cost of writing the manuscript. They're not looking at the life cycle for the patient, and I guess that adds another level of complexity to it. And I think it's also worth learning from history. I think about when I was at medical school, Shaji, though, when I guess the first was the estrogen receptor, when that popped up, and it was like, wow, this is fascinating. That's going to really change things. But now we have so many of these, and so much is being learnt about, as you said, epigenetics as well. Fascinating. So at the American Society of Hematology annual meeting last year, 2024, you chaired a session entitled Newly Diagnosed Multiple Myeloma, Many Choices and More Questions. To recap, what are the key advances and challenges in treating patients newly diagnosed with multiple myeloma?
Yeah, definitely, Jonathan. I think, as I mentioned again, the survival of patients have improved considerably. And the reason why that has happened is manifold, but the most important factor has been the development of new therapies. So, since the turn of the century, we have had roughly about a dozen and a half new therapies that have been approved for treatment of multiple myeloma. We have immunomodulatory drugs, there are three drugs in that group. We have proteasome inhibitors, there are three drugs within that group. Monoclonal antibodies, again, three different ones have been approved. And in the past few years, we have seen the immunotherapies emerge, especially immunotherapies that are facilitating the T cell redirection or the allowing the T cells to more effectively control the tumor. And those include chimeric antigen receptor T cell therapies or CAR Ts, where we have modified T cell receptors that are again allowing the modified T cells to target the myeloma cells, tumor cells in general. And we have two of them that have been approved for treatment in multiple myeloma. And we have what we call the bispecific antibodies that are allowing, again, the innate T cells to be better redirected towards the tumor cells in order to have effective tumor cell kill. And we have three of them approved, and two of them against one antigen, and the third one against a different antigen. And finally, we have again ADCs or antibody drug conjugates, where instead of just having an immunotherapy or monoclonal antibody, we have a monoclonal antibody that's carrying a payload that can be selectively destructive to the tumor cell. So considerable progress has been made in terms of the therapeutic options that we have. Now, it's not just individual drugs that are important for this disease, it is the way we can assemble these different drugs into very effective combinations. And given that we have a disease like myeloma that eventually finds its way to evade the treatments and develop mechanisms that allow it to escape the treatments, it's very clear that we have to use multiple different drugs in combination to be very effective. And again, this is nothing unique to myeloma. This has been the story for cancer therapy in general, particularly for hematological malignancies, where the success stories have all been um, based on using very effective combinations to control the disease or eliminate most of the disease, and in some cases, continuing therapy for long periods of time with different sets of drugs to try and eliminate those residual cancer cells. So in myeloma, the same story has unfolded over the past 2 decades. We started using these new therapies individually first, then we started combining two of them, then we started making it into three drug combinations, and finally now we are using four drug combinations for the initial treatment of multiple myeloma. So during this time frame, as we have come up with these combinations, we have been able to achieve deeper and deeper responses. And we know that the deeper responses, particularly if we can get patients to be minimal residual disease negative, they are able to now control the disease for long periods of time. So the deeper we go, the longer it takes for the tumor clone to grow back up. Unfortunately, the majority of the patients, the tumor clone does grow up. I don't think we have yet get gotten to a point where we have that depth of eradication that these tumors won't grow back at all in some patients. We are getting there, but not there yet. So the more recently now we have obviously these four drug combinations we try to use in all patients with myeloma. Obviously, the challenge in using the four drug therapies is that not every patient is going to be able to tolerate these intense therapies. So we have a balance, so to speak, the four drug intense regimens that can give you deep responses, balanced by the ability of the patients to actually tolerate these therapies. So the frailty of the patient is an important determinant of what can actually be given. Similarly, the other important factor that we already talked about is the underlying disease risk or the disease biology that is a reflection or drives the disease behavior. So the higher the risk the disease has, the higher the set of genetic abnormalities they have, the more intense we want the therapy to be. However, how intense a therapy we can deliver to the patient is in turn determined by how frail or strong the patient is. So eventually the treatment that we give to a patient in front of us is determined by that balance between the underlying disease risk and the frailty of the patients. So the higher the disease risk, the more intense we want the therapy to be, more the frailty, the less intense the therapy we are able to give. So I think that's where this the studies and the results we have gotten from the clinical trials and the individual assessment of the patients becomes very critical. So I think to some extent that is driving the individualization of therapy that we have in practice today. Obviously, one might not call it as a precision medicine because we are not really looking at a precise or a specific genetic abnormality and say we are going to use drug A against abnormality X and drug B against abnormality Y. We are not quite there yet for myeloma, partly because it's a very heterogeneous disease. Most patients have some subclone that has any genetic abnormality that has been described. So it is very different than something like chronic myelogenous leukemia, where there is a single abnormality that drives the disease, where we can say, okay, you're going to use imatinib for um, CML because it has a specific abnormality that can be addressed by that drug. That is not the paradigm we see in myeloma. We know there can be a dozen different genetic mutations that can be seen. We have about a dozen different chromosomal abnormalities we can see. But they all tend to be present to varying extent in patients. So we cannot just say one drug is going to control the disease. So what we are doing instead is trying to use this multi-drug combinations and giving them as intensive therapy that the patient can tolerate. The second important aspect of individualization has been how long do we continue therapy? The higher the risk, lower the frailty, the longer we can continue the treatment. Again, it all ends up being that balance between the frailty and the disease risk. And once you start treatment, there's a third element that comes in, which is the toxicity of the drug. So the lower the toxicity, the longer you can continue the therapy. So we continuously readjust therapy for patients based on these three risk factors or three factors. And then the final element that influences the duration and intensity of therapy is a response to the treatment. So if we can get patients to a deep response, say MRD negativity, there is probably a subgroup of patients where we can discontinue treatment sooner than later. Whereas if you don't get to a deep response and if you have a high risk disease and if you're not frail, then we try to push as hard as we can for as long as we can.
How well tolerated are these new combination regimes?
They are reasonably well tolerated. Again, they all have their own unique side effects, but in a given patient, some of it is often dictated by the underlying comorbidities. So let's take example the drug bortezomib. We are limited by some of the side effects like neuropathy. So if there are underlying neuropathy, there's only so much we can do. If their bone marrow reserve is rather limited and they get cytopenias, then there is so much we can push the dose of drugs like lenalidomide. Of course, the disease itself as well as the therapies can increase the risk of infection. So that is something that we have to constantly be on the lookout for. But in general, I would say a person who is in a good physical functional status, if you don't get any major side effects, can continue to lead a very normal life getting these four drug combinations.
Okay. So, changing topic a little bit, there was a key update in the 2024 to 25 National Comprehensive Cancer Network guidelines, and it's the adoption of quadruplet regimes as the new standard of care, as you've just been talking about. How has that impacted clinical decision making more than you've already discussed, especially in terms of patient outcomes? Because as you were explaining it to me, I'm thinking some of this is obviously predicated on very carefully organized clinical trials, but presumably you have ongoing registries and are looking at outcomes and then looking at the variables like patient age, frailty, how they tolerate it, and what the response rates. Have at it.
Yeah, absolutely. I think you bring up a very important point because the clinical trials are often idealized situations that don't reflect the real world practice. I would say probably 70 to 80% of what we see in the clinic don't necessarily reflect what happens in the clinical trials. And the patients we see, the majority of them probably would not make it to the clinical trial because of all the inclusion and exclusion criteria that accompanies these trials. So there's a lot of interest in trying to get real world data out there to really understand how these new advances in therapy actually behave in the real world practice. Now, it can be quite different. For example, immunotherapies, right? The CAR T results that we see in the phase 3 trials um, were, or in the phase 1 trials, were quite similar to what was subsequently seen in the real world studies. Um, but there are also instances where the outcomes were quite disparate from what was seen in the clinical trial. So I think it's important for us to continue to collect data through either national registries, individual institution studies, or many collaborative efforts that are ongoing to get a better sense of how patients behave with the therapies, what kind of outcomes are we getting, what modifications are we needing to make in order to make these therapies more effective. And I think it can affect a variety of different aspects, right? So one of them is dosing of the drugs. So many of these clinical trials are done using doses that have been determined based on a small groups of patients. And myeloma, it's replete with examples of how that has happened. A good example is bortezomib. It was originally introduced as a IV drug given twice weekly, but was associated with very high neuropathy rates. Subsequently, large experiences in the real world setting showed that you can do it once a week and still have quite a bit of same efficacy, but lot less neuropathy. The same studies subsequently showed that giving it subcutaneously instead of IV can lead to lower rates of neuropathy without any impact on the efficacy. So over the years, the treatment evolved from bortezomib being given IV twice a week to given subcutaneously once a week. Same efficacy, but a lot less neuropathy than what was seen. Another example is again what we have seen with drugs like carfilzomib, another proteasome inhibitor, drug like pomalidomide, which is an immunomodulatory drug. All the clinical trials with pomalidomide was done with 4 milligrams given daily. We know from a lot of the real world experience, 2 milligrams given daily probably gives you the same efficacy, but with a lot less toxicity. So I think the real world evidence allows us to, again, evolve the dose, the schedule of the regimens that we are using, but also allows us to um, give the most efficacious approach without necessarily compromising or without increasing the toxicity. A good example is the bispecific antibodies. We have, many of those bispecific antibodies, especially the approved ones, have been associated with high infection rate. But many of us in the practice start decreasing the dose frequency and maybe even stop the therapy in some patients once they get to a deep response. And this has been associated with a lot less risk of infections. And this in turn has been incorporated into many of the clinical trials now going forward, proactively decreasing the dose and frequency of these medications. So I think learning from the real world data is very, very important. And as we said in the beginning, the NCCN guidelines being updated, of course, we always want to keep it updated based on the most current data. And in line with all the phase 3 trials reading out the quadruplets being more effective, the last iteration of the NCCN guidelines updated the initial therapy of myeloma to universally use quadruplet regimens where feasible. Now, there's always going to be a gap between guidelines updated and the actual practice. When we went from a doublet to triplet, it probably took about a decade for that to be widely adopted in the community. Now, when you're going from a triplet to quadruplet, hopefully it won't take a decade, but it'll be much sooner that these will be taken up by the practice. So guidelines like the NCCN guidelines often incorporate clinical trial data, but also some of the real world data in order to come up with those recommendations. And I'll, kind of tells the practitioners what are the different options they have for a given patient in front of them.
That's fascinating. Thank you very much for that. So you've mentioned clinical trials. You've been the principal investigator on multiple phase 1, 2, and 3 trials for plasma cell malignancies. What are some of the most promising things that you're seeing out there, treatment approaches that you've currently or recently investigated, and how do these approaches aim to improve outcomes for myeloma patients?
Yeah, so we are exploring a bunch of different approaches in myeloma, right? So maybe I'll start off with one that I think is going to be important for cancers in general, that is early intervention. So, myeloma is a cancer where we can theoretically identify this almost 15 years before the myeloma actually happens, because it's always preceded by what we call a monoclonal gammopathy of undetermined significance. We think on an average it takes about 15 years from the onset of the MGUS to actually patients getting active myeloma. And we have a variety of different risk stratification systems which can tell us who are at a high risk of progression to active myeloma. And in fact, now we have 3 phase 3 trials that have shown that we can give myeloma type therapies with less intensity and for less duration in patients with high risk smoldering myeloma and delay the progression to active myeloma, and maybe even, in fact, improve the overall survival of these patients. So I think this whole concept of early intervention is going to be an important aspect in the coming decade. And I suspect many patients, if they are identified on time with smoldering myeloma, treated for a defined period of time, they may never have to deal with active myeloma. And this is very relevant because we are talking about a disease with a median age of onset of about 67 years. So you'll take a 75-year-old individual, identify that they have high risk smoldering myeloma that's going to become myeloma in the next 3 to 4 years. We give them 2 to 3 years worth of treatment, and if their likelihood of getting myeloma in the subsequent 15 years is eliminated, now we are talking about them being 90 years of age, and we may not have to ever deal with it because there's going to be something else that's going to happen rather than myeloma. So I think it may not be the paradigm for somebody who is 35 or 40 when they're diagnosed with smoldering myeloma. There we might still have to deal with it. But if we can delay that lifelong commitment to therapy by another 10 or 15 years, I think that's good quality life gained for those individuals. So this is an area of active investigation right now. Now let's take the instance where people already have myeloma. How can we use these current quadruplet therapies, transplant immunotherapies to give the maximum duration of benefit? Now, some of the recent phase 3 trials in transplant eligible patients suggest that we have a median progression free survival that may be reaching 15 years. So, we are talking about maybe a 55-year-old diagnosed today getting a quadruplet induction therapy, a transplant, two drug maintenance may be given for, again, intention is indefinite, but may be limited by the fact that if they have deep response, we may be able to stop it. That their myeloma may not come back until they are 70. It's not going to happen for everyone, but it's certainly going to happen for some individuals.
Sure.
And that means they may not need to get one more than 2 or 3 lines of treatment for their myeloma during their lifetime. So I think we are certainly inching towards the ability to cure this disease, at least functionally cure the disease, so that people don't die of myeloma, but they may die of something else. Now, obviously, what we really need to find out is how best can we leverage all the tools that we have, particularly the immunotherapies, the CAR T cells and the bispecific antibodies. Do we have an opportunity to use them much early in the course of the disease so that we can now go from this 15-year progression-free survival to maybe 25-year progression-free survival? But at the same time not commit them to 5, 7, 8 years of therapy to get that 15 years. Maybe give treatment only for 2 years and still get the myeloma to stay away for 15 years. So that's kind of what we are working on in terms of clinical trials and approaches to improve the outcomes of patients.
Yeah, it's fascinating to think that also, I guess, the order that you deploy these medications when, new and better comes along, do you go first with that, you know, or do you keep that in reserve? It's fascinating. I mean, my brain is spinning. I'm just a simple surgeon. This is complex stuff, but it again, my hat is off to your profession for the advances that you have made in my professional lifetime. As you say, 20 years ago, 3 years now, 12 to 15 years. Um, we've talked a little bit about the things that affect uh, the outcome and impact um, how we identify better treatments. How does understanding the bone marrow microenvironment in multiple myeloma play into this?
Yeah, that's a facet that has been known for a long time, but not a lot that could have been done to directly affect the bone marrow microenvironment. So studies, from 3 decades ago have shown that there are cells within the bone marrow microenvironment, the immune cells, the stromal cells, all of which play a role both ways, trying to control the tumor cells in terms of immune system as well as stimulate them to grow in us when we think about certain stromal cells or immune cells. I think we are starting to understand that a lot better now than what we did then, primarily because of the evolution of technology, right? The ability to look at individual cells, the whole microenvironment at a single cell level, I think has given us a better sense of the heterogeneity of the tumor microenvironment, what differential role these different cells might play in terms of either promoting or controlling the tumor cells. Now take that information and match it up with all the immunotherapies that we have right now that can enhance the efficacy of the T cells. I think we are in a great place right now for us to, bring in another layer of that individualization of treatment for myeloma patients, where we can hopefully profile that microenvironment and say, yes, in this particular individual, these immune cells are not doing the job what they're supposed to do. Maybe this particular immunotherapy can be used. Or we can say a specific mutation that these myeloma cells have is what is preventing them from responding to this immunotherapy. Let's try a different immunotherapy for that patient. So I think an understanding of the changes at the level of the tumor cell, changes at the level of individual cells in the bone marrow microenvironment, coupled with a growing portfolio of therapies we have with different mechanism of action, will allow us to get to that point where we say this patient is going to get these three drugs and that patient is going to get those three drugs.
Interesting. Interesting. So, Shaji, when I prepare for these uh, lovely conversations, I like to go through a CV. I know if someone was going through my CV, I know exactly which paper I would ask me about. And I found the one that I have to ask you about. You've got a very impressive CV, but I found a paper that I couldn't access online, Blind Men and an Elephant. And it was published in 2015 in Blood. And I know that there's a moral behind the story about forming opinions based on incomplete data. So I'd love you to tell us about the article, but first, tell people about the parable, the fable, if you will, behind blind men and an elephant.
Absolutely, yeah. It's
Great, by the way. It's a great title.
it's again something I think everyone can identify with, because I'm sure they all would have heard those stories. And again, it's it, as you said, it points to as a concept of, again, bunch of blind men looking at the elephant. One is feeling the trunk and saying, "Oh, this elephant is like a tube. It's round and long." And somebody is looking at the tail and saying, "Oh, this is elephant is hairy." And someone's looking at the wrapping their arms around the legs and say, "Oh, this is so and so forth." And so clearly, you know, the aspect of the disease that one is looking at might give you a very different picture. And I think myeloma is a good example of that. Again, pointing towards the heterogeneity of what we talked about, right? So somebody can look at the myeloma patient and look at the, let's say, the bone disease, and come away with something. And but there could be an aspect, of their behavior that may be determined by the genetic abnormalities, and may, unless you look at it, we won't appreciate it. So I think it's important thing is, the message there was that we really need to look at the whole picture. you know how how's the patient presenting in the clinic, what kind of risk factors does the patient's myeloma have, what are the comorbidities that particular patient has. So really have to think about a wholesome approach that takes care of all the different things. We need to take care of the tumor, we need to take care of the patient, we need to take care of the side effects that the tumor has induced on the patient, we need to take care of the toxicities that might come from the treatment that we're going to give these patients. So I think that holistic approach is extremely important for treatment of multiple myeloma. And I think it's important for us to just not make opinion or form opinions just based on one aspect of the disease.
Yeah, I always remember I was participating in an activity on deploying evidence-based medicine to try and influence a certain decision that certain people were not making in medicine. It was actually the deployment of it was preventing catheter-related bloodstream infections. And one chap in the audience stood up and said, "Well, you can quote all the CDC guidelines and all the level one evidence you want. I have my experience to guide me." And it's like, thank you, sir. You've just put the process of injecting science into what we do back 20 years. So with that, I'm going to put the process of science back several thousand years and say to you, if you came across a magical genie who granted you three wishes for the area of healthcare that you practice in, Professor Shaji Kumar, what would your wishes be?
The three wishes would be: one, if we can identify myeloma early and intervening, can we give them a treatment, maybe a year's worth, and they will never have myeloma? Can we cure by intervening early? If we can get a treatment that we give them once, and even patients who get myeloma, having a treatment that is limited duration and completely eradicate the disease and it never comes back, that would be the second wish. And even if we cannot cure them, have being able to control the disease long enough that people don't die of myeloma anymore, that would be the third scenario, I think, that would be a win-win.
Yeah. I love how focused you are in your area of interest. You're clearly very, very passionate and certainly very knowledgeable about it. Unfortunately, that's all we've got time for today, but it's been delightful chatting to you, Professor Shaji Kumar. Thank you for being with us today, for everything you do for patients and for the science of hemato-oncology. It's a real pleasure chatting with you.
Thank you, Jonathan, for having me.
Well, I hope you enjoyed that episode of Hema Now, our bi weekly podcast on hematology. Please consider subscribing on either Apple Podcasts or Spotify, or frankly, wherever you get your podcasts, so that you never miss an episode. Like us on social media, tell your friends and colleagues, and please check out the archives because they're growing if you've missed any episodes. And please join us again in 2 weeks for another episode. Until then, I'm Dr. Jonathan Sacchi. I'm proud to be your host. Please, everyone, stay safe, stay well, stay curious. Bye for now.